Hello, and welcome to our listeners around the world. You're listening to JAMAevidence, our podcast series based on core issues in evidence-based medicine. Today, we're discussing the use of historical controls in clinical trials. I'm your host, Dr. Roger Lewis, Senior Statistical Editor for JAMA and editor of the JAMA Guide to Statistics and Methods series. I'm here with Andrew Althouse. Andrew, could you go ahead and introduce yourself to our listeners?
Sure, Roger. Thank you very much for having me. My name is Andrew Althouse. I am a senior principal statistician at Medtronic, recently transitioned after spending about 10 years at the University of Pittsburgh in the University of Pittsburgh School of Medicine.
So, in introducing this topic that you covered in your article, let's start with what are usual controls in clinical trials and why are they important?
So the most common research design I think we're used to seeing is the randomized controlled trial, where we have two treatment groups. People perhaps have been randomized to receive the treatment of interest that we're looking to study and a control group that could be a placebo if there's no approved therapy or medication, or it could be something like a standard of care group where people in the control group are receiving the standard of care and people in the experimental group are receiving the new treatment, the novel treatment that we're trying to study.
So, what are the advantages of using a concurrently randomized control group like that?
There's a number of advantages. One of them is it eliminates the potential for a systematic bias in allocation to the two groups, meaning essentially you can expect the people in one treatment group to be like the people in the other treatment group. Now, people most commonly think of this when it comes to patient factors like age or perhaps their comorbidity burden. But you used another word that I want to hit on here, which is concurrent. And what that means is that people in the treatment group and people in the control group that you're studying are being treated at the same time in the same centers by the same people, essentially, in the aggregate.
So, if that's a good way of reducing bias and making sure the groups are comparable, why don't we always do that?
Now, unfortunately, there's sometimes when that's not necessarily possible. Sometimes we have a rare disease situation where there's not that many patients available, and it's very difficult to get the patients who are available to enroll in a study, where they might not be randomized to receive the treatment that we're trying to study. There are certain populations, such as pediatrics, where sometimes there's extra difficulties in doing a randomized trial. There are some research questions that are not always that amenable to a randomized trial. For example, something like a surgical technique often is one that is cited, where if you've introduced a new surgical technique, people will argue that it's very difficult to encourage people to randomize to using the newer surgical approach versus maybe an older type of approach, and they might reach for a little bit different design.
So, your article focuses on the use of historical controls. So, in contrast to concurrent controls, what are historical controls?
It's kind of just what it sounds like. Historical control is when you go to some other data source, usually historical meaning already existing or previously collected from somewhere, to try to come up with a group of patients that can serve as the control group against which we might compare our new patients. So to stick with that surgery example for a moment, suppose you introduced a new surgical approach and you treated 100 patients at your center with that surgical approach. An example of historical controls would be you going to your records and obtaining maybe the 100 patients that you've done before the new approach and using those 100 patients, those previous 100 patients, as the control group to compare your outcomes with the new approach against those historical patients.
Starting with the advantages, what do you see as the advantages of that approach to evaluating your new technique, both from the investigator point of view and perhaps more importantly from the patient point of view?
The advantage from the investigator point of view is it's not as expensive and time intensive because you can just introduce your new approach, do a certain number of patients, and then compare them to the historical patients. Whereas if you're going to use a concurrent randomized comparison, you need more patients because only half of the people who enroll after starting that new approach will actually receive the new approach. And we're just sticking with round numbers here, but suppose you want to have 100 control patients and 100 treatment patients for a comparison, and today is day 0, so you're going to enroll your first patient. If you want to do a concurrent randomized trial, you need to do 200 patients from today to get your 100 treated patients and your 100 control patients. Whereas if you're willing to use historical controls, you can just do 100 from today instead of 200 and compare those 100 that you do from today against the 100 historical controls. So it saves time and some amount of expense. Another advantage can be in terms of resourcing, getting the approvals necessary and the funding necessary to do a randomized trial as opposed to pre-post comparison with historical controls. Sometimes it can be easier to do that.
And what are the advantages from the patient's perspective?
I think from the patient's perspective, the most commonly sold advantage would be that you're going to get the experimental treatment, which we hope is kind of the latest and greatest. Now, that obviously can be challenging. That's not always going to be true. I do think from the patient perspective, one perception would be that they're guaranteed to get the experimental treatment. And that obviously I think is going to be a little bit context dependent. For example, in cases where there's no currently approved therapeutic option, some people are willing to take the chance on any treatment, even if it's not proven to be clinically effective. And if you're giving them the choice to enroll in a randomized study where they might be assigned to placebo versus the experimental treatment, they might not like the idea of enrolling in that study if there's a possibility they could be randomized to placebo, because what they really want is the experimental treatment. And in that case, a single-arm study where you enroll patients and then just compare them to historical controls, it might be more amenable to a patient because when they enroll in that study, they're told they know they're going to get the experimental treatment. One other thing that patients may like about it is it provides a little bit more of an element of certainty. They understand what they're going to get. People can really be a little bit put off sometimes by the idea of randomization, the thought that they don't know which treatment they're going to be randomized to. And at least where they're enrolled in a study of a single arm study of the experimental therapy, they know for certain that's what they're going to get. And they're accepting perhaps the risks and benefits that might come with that.
So now that we've talked about the advantages, let's switch to the other side, the disadvantages of this approach. So what do you see as the major problems with this approach, specifically those that might affect the validity or reliability of the conclusions of the trial?
I think one of the biggest disadvantages to this approach in comparison to the traditional randomized controlled trial is the potential for confounding variables. And sometimes that can be patient-level variables, like the historical control patients are just a little bit different than the patients who are in the experimental research protocol. But it also can include changes in the standard of care over time. And what I mean by that is as time moves forward, presumably we'd like to think we're always getting better. So perhaps today, in the more contemporary era, people have access to some other supportive treatments for a particular disease or condition that were not available at the time the historical controls were treated. So what it really introduces is this potential for another source of bias between your historical controls and your contemporary patients that not only maybe are the patients themselves different, but the care that they were receiving other than the therapy that you're trying to test also could be different. If patients today have access to some other supportive treatment, if advances have been made in our understanding of the disease and how to manage it, they might get something else basically that's kind of done that might help them that wasn't necessarily available to the historical control patients.
So in other words, there might be differences between those historical patients or their treatment that is something other than the treatments that we're comparing. Is that fair?
Exactly right. The beautiful thing about a contemporary randomized controlled trial is that when you've got patients drawn from the same population, treated in the same centers by the same people, you can trust that really, for the most part, the only thing that's going to be different about the two groups is that the experimental treatment that you're trying to test. When you use a historical control population, that's no longer guaranteed to be true.
Since that's a risk that might threaten the validity of the conclusions, what do we do to assess whether that risk actually occurred and we should doubt the results of a study that uses historical controls?
The first, most obvious thing is comparing the characteristics that you have of the patients. See, do the patients who are in the historical control population look similar to the patients that were in the contemporary population treated with the experimental approach. And really, that's specific to a particular therapeutic area. Obviously, there are certain demographic factors that you might want to see are similar, but you also want to know that the factors that we think affect clinical outcomes for those patients are similar between the two. So if we're talking about perhaps a cardiology population, you want to see that their cardiovascular risk is similar in the historical controls as compared to the experimental patients. One other thing that I do want to make sure we mention is that it's not just about the patient factors, but you also have to think a little bit about the data collection and the research protocol. So if the data collection is done very differently for the historical controls than it was for the contemporary patients, that's another potential source of error. I'm thinking perhaps an example where you have some sort of registry where you obtain the outcomes for the historical controls, and then you compare them against outcomes that are adjudicated under a specific research protocol for the experimental patients. You're not talking about data that was collected exactly the same way anymore. So on the flip side of that, if you have people where they were basically done in a very similar research protocol, like suppose you have one clinical trial and then you have another clinical trial, and they were done with very similar research protocols by similar personnel and similar centers, I think you have a little bit more confidence that the controls from that first trial could map a little bit better as a control arm for that second trial, as opposed to a situation where maybe they're collected in a different way.
So, in a sense, what you're saying is that not all historical controls are the same, and there's actually some qualitative judgments regarding how appropriate they are for a given use. Is that fair?
That's very true. When you're thinking about the appropriateness of historical controls, I think you do have to look at both those patient factors and those qualitative factors of was the data collected the same way from a fairly similar source and things like that, for sure.
So, if there are these potential limitations to analyses or conclusions that are based on historical controls, what are the alternatives to taking this approach in settings in which you can't do a fully randomized control group?
One option would be something like a performance goal. Suppose you have a target, like you want to meet a certain cure rate, for example. Suppose we're talking about an oncology setting and you've got some measure of if the disease is in remission. And you might say, if we achieve a remission rate of 50%, then we'll consider the therapy to be successful. The tricky thing about that is that performance goal usually has to come from somewhere. And it usually is going to be coming from some other published studies. So it's actually kind of similar to using historical controls, but without using individual persons' data as the historical controls. It's almost like just using historical data to create a performance target, like maybe saying that, well, some other therapies that have been approved in this area had a remission rate of 50%. So we're going to say that if a new therapy can prove that it has a remission rate of greater than 50%, we're willing to approve it. It's interesting because that's something we can talk about a little bit as an alternative to historical controls, but it's really almost just using historical controls in a little different way to set that target and then try to prove that you can exceed it. Why we might use that is that in some cases, you might have some published literature that allows you to come up with that performance goal or that target, but you might not have access to the individual patient level data. And then using a performance goal is a way where you can still kind of use that approach. So if we want to use historical controls without using the performance goal approach, another thing that you might be able to do is use historical control data to augment concurrent randomized controlled trial, where you're going to enroll some patients and you're still going to do some randomization. But by using that historical control data, you need fewer control patients than if you were starting as though the historical control data did not exist. So this way, you can still run a randomized trial, you can make use of that historical control data, and then you can reduce the total number of patients that end up getting allocated to control while still getting some randomized data, but leveraging that historical control data as well.
So, in that setting, you might, for example, randomize patients asymmetrically, for example, 3-to-1 to the experimental and the control. Is that right?
Yeah, that would certainly be one way of doing it, for sure.
So, in the article that you wrote, you used a specific example of the use of historical control. Can you tell us about that example?
So this example was really interesting. I have to admit, I'd never seen something exactly like this before. What you had in here was the investigators had a prior randomized controlled trial of one agent that had been compared against a placebo. And they were now doing a trial of a second version, a new agent. And they wanted to compare that second agent and get an estimate of what that second agent would be against placebo. But they didn't really feel that it was appropriate to do another full randomized protocol comparing that second agent against a placebo, given that the first agent was already available. So what they did is they did a randomized trial where they actually randomized patients to that second agent, that new agent, and they compared them to the placebo arm from that first trial. Now, the nice thing about this, calling back to something that we spoke about a few moments ago, is these trial protocols were done almost identically. It's almost like an extension of the first trial. So the nice thing about that is that it boosts our confidence that the data collection has been done very similarly. We're talking about the same instruments administered in a very similar research protocol, administered in very similar settings. So we have some confidence that at least the data collection between the historical controls and the patients receiving that experimental agent is really pretty similar. The only thing that we don't have is that concurrency. So there is at least a little bit of a temporal trend here where people in the new research protocol are at least a few years later than patients in the first research protocol. So they're not being treated at exactly the same time. And they're not patients that have been randomized directly to that second agent against placebo. You're taking placebo patients from that first trial and comparing them against patients who received the new agent in that second trial.
So what did the authors do to try to convince us, if you will, that the old control patients were similar to the new treatment patients?
And they did a couple of things. One is they showed the data very transparently and compared the treatment groups to try to illustrate that the patients themselves had sort of a similar distribution of clinical characteristics. They also used an approach called propensity score weighting, which is a little bit technical, but essentially a propensity score is where you take patients in a treatment group and a control group, and you use their baseline characteristics to try to come up with a probability that a patient is in the treatment group. And you might say, well, that's silly. You already know whether they're in the treatment group or the control group. But this is actually a really clever way to create a similar distribution of patients who are in a treatment group and a control group. So you can calculate these probabilities and then apply weights to each patient. And what that does in aggregate is it creates groups that have an overall similar distribution of those measured baseline factors. And you can trust that once you've done that, the treatment effect that you're estimating is at least closer to the isolated impact of the treatment group itself and not those confounding factors.
So to summarize, they took two different approaches. One, to actually compare the characteristics of the groups, and then secondly, to try to adjust using propensity scores for the differences that were seen and look for a consistency of results. Is that fair?
Correct.
Okay. So what did they actually find, and how do you interpret it?
So they found that this agent showed a tremendous treatment benefit, a very large reduction in the outcome measures that they were interested in compared to patients that had been in that placebo group for the first trial. So with an impact of this magnitude, like I said, these are very large treatment effect estimates. I think we can be fairly confident that even if there had been some amount of residual confounding, these really are overwhelmingly positive results for this agent, suggesting that patients who received this agent did much better than patients receiving placebo from that historical control group.
So, Andrew, for our listeners, in summary, what do you think the main take-home points should be from your article?
I think that the key takeaways here are there are times when it might be difficult to do our randomized controlled trial. And in those situations, we might turn to historical controls as a way to try to get some idea of whether a particular treatment is better than not receiving that treatment. Ways that you can try to assess the trustworthiness of historical controls are comparing the patient groups in the historical controls to the people who got the experimental treatment to see if they seem to be similar, and thinking about the data sources and data quality likely to underlie the data that's been collected. So if they seem to have been collected in a fairly similar way, something like them being collected in similar research protocols, that would increase your confidence that the historical controls and their data are comparable to the patients receiving the experimental treatment.
I'm Roger Lewis, and I've been speaking with Andrew Althouse about the use of historical controls in clinical trials. You can find a link to the article in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.